It's working now. Okay. Okay. Very good afternoon. Today I'll be continuing from the previous class regarding the glaucoma management. So first, last time I told you till perimetry and visual field examination. Today, some few other tests which we do for to evaluate glaucoma patients. These are the subjective and objective tests. The subjective tests are mostly the photography and stereoscopic. These tests are usually not. These tests are good for patient follow up, but they are not so reproducible. That's why we have a need for objective test. Uh, so objective test, the most important test in objective test is OCT, that is optical coherence tomography. As we know, OCT is also used in macular disorders. It has equal importance in cases of glaucoma, where we have doubtful cases or complicated cases. There OCT is useful. Other two methods, that is SLP, scanning laser polarimetry, and HRT, these two are relatively less used nowadays. And the last three methods, that is FDT, matrix perimetry, and red bit perimetry, these are nothing but the modifications of our white on white or white on yellow perimetry. What happens sometimes, as I told you, because of the glaucomatous damage, the perimetry changes appear very late. That is, about 40 to 50% of the retinal ganglion cell has already been lost when there is a change in the perimetry. So there is a need to devise new devices which can pick up these changes very early. So these are the nothing but the modifications. There are different type of ganglion cells, and so these focus on those ganglion cells which are lost early, so that we can diagnose glaucoma in early phases. A little bit about OCT. OCT is nothing but it is a 3D evaluation of the optic nerve head, that is optic disc, and it also measures the functions of retinal nerve fiber layer. That is, in case, as I told you, in cases of glaucoma, there is thinning of the retinal nerve fiber layer. So if we do OCT, we get the information about the retinal nerve fiber layer. And the recent advances in this field is that nowadays people are using what is called as GCC, or ganglion cell complex. That is, at macula we measure the ganglion cells, and if they are lost, if there is thinning of the macula at beyond a point, we get to know that there is already some damage has happened. So OCT gives us four informations, that is neural rim, that is here you can see this is the fundus photography. So neural retinal rim, we can find out whether there is increase in the cup area, that will find out, and what is the thickness of the retinal nerve fiber layer. And nowadays, as I told you, we have GCC complex also. There are two variations of primary open angle glaucoma. One is called ocular hypertension, other is called as normal tension glaucoma, or NTG. So what is ocular hypertension? It is seen in about 4 to 7% of the population. Here IOP is more than 21 millimeter of mercury, but there is no glaucomatous damage. As I told you in my first class regarding the definition of glaucoma, you have to have three things. That is, there should be IOP more than 21 millimeter of mercury. There should be some visual field defects on the perimetry. There should be some related optic nerve head changes. So all these features, if they are there, then we say it is glaucoma. But in case of ocular hypertension, there is no other detectable findings. That is, there is no visual field of the patient is absolutely normal. The optic nerve of the optic disc of the patient is absolutely normal, but IOP is more than 21 millimeter. So what are the risk factors? Mostly the risk factors are age and the central corneal thickness. That is, if the corneal thickness is more, patient will have more IOP, because we are using what is called as a Goldman's applanation tonometer, which depends on the corneal thickness. Okay. And in patients with a high CD ratio, that can also be a risk factor for ocular hypertension. Myopia, diabetes mellitus, and male patients, these are all risk factors for ocular hypertension. What happens if we find patient with more than 21 millimeter of mercury? We should not send these patients. We should thoroughly evaluate these patients, especially central corneal thickness we have to measure, do a pachymetry, measure corneal thickness, and then follow up these patients. There is chance that these patients may go into glaucoma. The next entity is normal tension glaucoma, or what we call as NTG. The other name is normal pressure glaucoma. Here IOP is less than 21 millimeter of mercury, but there is glaucomatous optic nerve damage, and there is visual field loss. Angles are absolutely open, and there is no other features of secondary glaucomas. I'll be telling you in last class what are the secondary glaucomas. Okay. So, what are the risk factors for this? Risk factor, this occurs usually in the later age, that is 70, 80 years of the age. So, old patients, normal tension glaucoma is more common in old patients. That is more common in female patients and more common in Japanese. Those patients who have low central corneal thickness, they are also prone for NTG. And the new theories, what they say that these are not, there is a debate that whether it is a glaucoma or it is because of the abnormal vasoregulation. That is, there is any abnormality in the in the autoregulation of the optic nerve head, which causes this NTG. Okay, so systemic hypotension, obstructive sleep apnea syndrome, and thyroid disorders, all these are other risk factors for NTG. How do we diagnose? Patient may have sometimes history of migraine or episodes of shock, any head injury or any intracranial lesion. Sometimes patient have gone any surgery, like most of the patients there is a history of the blood loss. So all these are the present in history, and IOP is always less than 21 millimeter of mercury. The optic nerve head is usually larger. It is the optic disc is large, and there is acquired optic disc pit with splinter hemorrhages and focal nerve fiber layer defect with the peripapillary atrophy, which are more common. The typical visual field defect in cases of NTG is it is more closer to fixation, and it is deeper, steeper, and more localized. It is more of a local. So when you read a visual field chart, you will see that it is almost involving the fixation. So that's how we differentiate this from other type of glaucoma. In these patients, we have to investigate them for other diseases like systemic vascular risk factors, and we have to monitor blood pressure, and you have to speak to your physician whatever drugs they are giving. Any drug which is causing a decrease in which is causing hypotension, especially during the sleep, those drugs should be avoided, or they should be stopped, and they should be replaced. Now, what are the differential diagnosis of primary open-angle glaucoma? We have to differentiate it from other causes of increased IOP, and we have to differentiate from what are the causes of cupping and field defect. So, we have to differentiate POAG from ocular hypertension and secondary open-angle glaucomas and chronic angle closure glaucoma, because in secondary open-angle glaucomas are also very common entities. We have to differentiate it because the treatment varies. Here the main treatment in POAG is medical method. In case of secondary secondary open angle glaucoma, the mode of treatment mostly is a surgical modality. Okay, and other things are, you have to differentiate the cupping in case of glaucoma from physiological cupping, and optic nerve drusen and other types of optic atrophies like secondary optic atrophy or consecutive optic atrophy, that you have to differentiate. Now coming to the treatment of primary open angle glaucoma, once you have diagnosed a patient with POAG, patient is going to patient should be treated for lifelong. Okay, it is not it is a chronic disease. It will not resolve in one day. So you should have a very important is patient counseling in these patients, especially in our Indian scenarios. Most of the patients we have, once we start on treatment, drugs are costly. In one anti-glaucoma drug, it cost around 300-400 rupees. Most of the rural patients, they cannot afford so much of medication. So that's why we have to modify our treatment. Wherever indicated, we have to do surgery, and very important is the follow-up. We have seen many patients which we have started on treatment. They will land up with you after 5 years, 10 years with total glaucomatous optic atrophy, and once optic atrophy sets in, you cannot do anything. Okay, so what is the treatment of what is the aim of our treatment is to enhance or at least maintain patient's health. That is, we cannot reverse whatever damage has already been done, but we have to prevent from damage, from the further damage. And to achieve target IOP and decrease IOP fluctuations, most of the damage occurs because of this problem, IOP fluctuation, especially in the night time. Okay, and to administer medications which are having least side effects, because these I'll be telling some of these anti-glaucoma medications, they have a lot of side effects, and we have to consider patients affordability, and patient counseling, patient family counseling is very important in glaucoma cases. There is something called as a target IOP. This is not needed at your level. Just I'll brush up through this. This is nothing but IOP at which there is no damage, to the retinal ganglion cells. That is, you have to set. This is not a static number, but this is the dynamic number where you have to set a particular IOP above which there is no damage to the retinal ganglion cells. Okay, so usually this IOP is target IOP is 20%. If we reduce 20% from the baseline of the IOP, suppose patient presented with 30 millimeter of mercury, we have to reduce from 30 20% of the that we have to reduce. That is the nothing but target IOP. It keeps on changing every time patient will come, and every time we'll do some investigations. Not needed. So what are the guidelines for target IOPs? It is, if the patient's IOP is mid 20s or high 20s, then the target IOP is around 14 to 18 millimeter of mercury. But in advanced glaucoma, it becomes less than 15. Sometimes it becomes less than 10 millimeter of mercury also. Okay. And according to European Society guidelines, if yeah. So if patient's initial IOP is high, or the patient's age is old age, or damage is mild, in these cases we have to set a high target IOP. High means in upper 20s you have to keep. But if the patient's initial IOP and damage is low, and patient is young patients, that is he has long life expectancy, and damage is advanced, all these three conditions we have to set a low target IOP. Okay, so this particular concept is very important in treating any glaucoma patients. So first, what are the treatment guidelines? First, you have to start with medical treatment. Either you have to start with monotherapy or a combination therapy. So generally, if patient's IOP is more than 30 millimeter of mercury, you have to start with a combination. A single drug cannot decrease that much of IOP. If it is less than 30 millimeter, you can start with monotherapy. And in this order you have to go. Okay, so first start with medical therapy, then with laser trabeculoplasty. But there are always some patients in which we have to shuffle the order, but most of the patient, 95% of the patients, you have to follow this order. Okay, we can change this, but it depends on the patient presentation. So then next is laser trabeculoplasty, and third is filtration surgery with or without anti-metabolites. What are anti-metabolites? I'll tell you. And next you have to go with drainage implant devices, and last option is cyclodestructive surgery. If patient is not if it is not controlled with cyclodestructive surgery also, then next step is you have to go retrobulbar alcohol injection. If patient is not controlled with that also, you have to do enucleation or evisceration of the patient. Okay, so enucleation or evisceration is always the last option. Coming to medical therapy, the patient should be treated with the lowest concentration of the drug, and it should be the smallest number of medicine and with the fewest number of administration in a day. What does it mean? If the patient is controlled with OD dose, don't give patient BD or TID. Okay, most of the drugs nowadays are available with the BD doses, but some drugs have OD dose also. Okay, so monotherapy usually provides about 20% of the reduction, that is our target IOP. But if target IOP is not reached, then you have to add a different single agent. That is, we have to if we are using beta blocker, next time you have to use either alpha agonist or carbonic anhydrase inhibitors. Okay, and if the target intraocular pressure is still not achieved, then you have to add an adjunctive and uh, IOP lowering drugs. So other combination also you can give. So what are the anti-glaucoma drugs? These drugs are very important because they are not only asked in case of theory, but they are also asked in case of practical. They will be kept for table viva. So first, we divide anti-glaucoma drugs into two categories, that is aqueous suppressants and outflow enhancers, and some latest, third is hyperosmotic agents, and fourth is some latest drugs which I'll tell you. So first, going to aqueous suppressants, these are first and foremost important is beta blockers, which are non-selective. Example, timolol. Okay, timolol 0.5%. The mechanism of action is same for all the beta blockers, that is they decrease the aqueous production. Very important, you have to remember about the side effects of these drugs, okay, because these are old patients, they will have multiple systemic problems, so you have to give these drugs very carefully. So if patient has COPD or in asthma or congestive cardiac failure, you cannot give timolol, okay. So those are the uh, side effects and contraindications. And beta 1 selective drug is bitoxolol 0.5%. It causes ocular allergy and small epithelial erosion. So if patient is having, because this is the cheapest drug available and we start mostly with this drug, so if patient has any heart problem or any lung problem, we have to not give them timolol. That's what you should remember. So other second in this aqueous suppressant is alpha adrenergic agonist, that is alpha 2 selective. Two drugs are there, brimonidine and apraclonidine. Apraclonidine is not available in the market, so we have brimonidine 0.2%. It causes it blocks the beta receptors which are present on the ciliary processes, and it also causes outflow enhancer. So these drugs cause CNS depression, cystoid macular edema, and tachyphylaxis. So brimonidine is contraindicated in children. So if a child comes with glaucoma in childhood, previously I told you in developmental glaucoma or infantile glaucoma, you don't prescribe this brimonidine. Okay. Third drug in this category is carbonic anhydrase inhibitor. What it does, it inhibits the carbonic anhydrase enzyme which is present in the on the ciliary process and decrease the aqueous production. True drugs are available in this dorzolamide and brinzolamide. Most commonly used is brinzolamide 1%. And what it causes, what are the side effects are the metabolic acidosis, and it is contraindicated in compromised cornea because the corneal endothelium also have the same carbonic anhydrase enzyme. Okay, so that's why in those cases it is contraindicated. Coming to outflow enhancers, there are two drugs available. First is miotics, that is pilocarpine. It is available as 1%, 2% eye drop, or up to 25% of pilocarpine is also available. Okay, what it does, it causes the pupillary constriction, so because of which the outflow pathway increases, okay, through the conventional pathway. There is more space between the scleral spur and trabecular meshwork, so there is more enhanced flow of this aqueous humor. Okay, the side effects in these cases is brow pain and headache, and this it causes myopic shift in cases of refraction that leads to retinal detachment. So before putting patient on miotics, you have to do a thorough retinal examination just to rule out any breaks or any retinal tear is if it is there. Okay, the another important drug is prostaglandin analogs. There are many drugs available, and these are the usually drugs which are started if patient is affordable. These drugs are little costly, but they are very good drugs. So it causes outflow through the US scleral pathway. So this acts on the alternate pathway, not the conventional pathway. The side effects of prostaglandins are very commonly asked in the question in the exam. They are iris pigmentation, cystoid macular edema, anterior chamber inflammation. So it causes iritis, okay, and it causes some skin changes in the lids. and skin changes in the lids, and also pigmentation of the conjunctiva and sclera. So if patient is having a secondary glaucoma, unilateral glaucoma, these prostaglandin analogs are contraindicated. You should not prescribe them. Third is, what are the hyperosmotics? They work by decreasing the vitreous volume. So if we give these drugs, the water from the vitreous diffuses out into the circulation, and that's how it decreases the vitreous volume and decreases the intraocular pressure. The examples are mannitol and mannitol 20% and glycerin 50% orally. The side effects are the CNS overload and congestive cardiac failure or circulatory overload is most common complication. It can also cause hypokalemia and other complications. So most commonly drug used is the mannitol 20% IV. And these drugs are usually not used in case of POAG unless and until patient has very high initial presenting IOP and there is compromisation of the cornea. If patient has more than 40, 50, 60 millimeter of mercury, then we use. These drugs are usually used for secondary glaucoma and for angle closure glaucoma. Now, another drug I told you regarding the what are the recent advances in these. So, first drug is Rho kinase inhibitors. Rho kinase inhibitors are the latest drug. It is recently approved by FDA last year only for treatment of glaucoma. The other is Bilbo-Ginkova, that is also a type of drug, and many neuroprotective drugs are available in the market, which are on basically these are the research drugs. They don't have 100% efficacy. Whatever these drugs I told you, they have efficacy, but other drugs which are I'm telling you, these drugs don't have 100% proven efficacy. Okay. Now coming to how do you choose for combination therapy in cases of glaucoma. So first line therapy or monotherapy is, in our Indian scenario, if the patient is affordable, you go ahead with prostaglandin analog, mostly latanoprost. But if patient is not affordable, you go with beta blockers, that is timolol 0.5%. And second line medications are carbonic anhydrase inhibitors and alpha 2 agonist, mostly brimonidine. These are second line. And third line drugs are the dipivefrin or pilocarpine or oral carbonic anhydrase. I told you pilocarpine, oral carbonic anhydrase, these are the third line of drugs. Then what is the criteria for switch therapy or add any other drug? If the drug produces severe side effects or it is not able to reduce IOP by 20%, then we have to either switch therapy or add another drug. Or if IOP is reduced by 20% but target IOP is not reached, then also, and if target IOP is not reached by 3 topical medications, then we have to go ahead with laser out filtering surgery. Okay, so the maximum tolerable therapy is 3 medications, 3 topical medications. If they are also not decreasing IOP, then we have to go ahead with surgery. Now, what is the laser trabeculoplasty? It is nothing but by using argon laser or diode laser, we focus on the target area in the trabecular meshwork at the angle, and here we make a by here we give lasers. So there are two types of one is argon laser therapy and other is selective laser therapy. In selective laser therapy we use what we call ALT and SLT. In selective laser we use Nd:ARC. So in these cases of if we are using argon, it causes larger burns, and these burns will lead to contracture of the tissue and then it enhances the aqueous outflow. But in cases of SLT, there is we focus on the pigmented area of the epithelium and we hit those pigments so that there is biochemical changes in these pigments, and because of which the opening the trabecular meshwork opens and the aqueous humor goes out. Okay, so this is the principle of treatment for laser trabeculoplasty. There are about 50 burns which are given in 180 degree of area. The third line of treatment is non-penetrating glaucoma surgery. These surgeries are now coming up in clinical use. Mostly, these are drainage procedures which restore the aqueous humor outflow through the trabeculodesmatic membrane. So the three types of methods are deep sclerotomy, viscocanalostomy, and canaloplasty. What happens here is we do not disturb the trabecular meshwork. In case of trabeculectomy, which I am going to tell you next, there we disturb the trabecular meshwork. But these are nothing but we have to go inside that the canal, and we have to do the surgery where the trabecular meshwork is maintained. Okay, so if this surgery or non-penetrating glaucoma surgery fails, you have another option of doing a trabeculectomy. So the trabeculectomy is nothing but we have to make a opening into the trabecular meshwork, and the aqueous humor, it flows, it goes into the subconjunctival tissue and flows into the systemic circulation. Okay, that's how it decreases the IOP. How the surgery is done, what is the procedure, I'll tell you in next class. Okay, because that is important surgery. The other things are yeah, the other things are the drainage, other drainage shunts. These are nothing but we have to there is a ring and it has a tube, so we have to insert this tube inside the anterior chamber, so that the aqueous humor which is there in the anterior chamber, it comes in through this opening, it comes into the subconjunctival space and it is drained into the systemic circulation. This is the next procedure after your trabeculectomy fails. There is multiple failure of trabeculectomy, or if patient has any secondary complications, suppose patient has neovascular glaucoma or other type of uveitic glaucoma. Those cases, even if you do your normal shunt surgery or normal trabeculectomy, that procedure will fail. So in those cases, we have to do what is called as we have to use drainage shunt device. Okay. So the shunt uses EP-scleral explant. This is the explant. These create a communication between the anterior chamber and subtenal space or subconjunctival space. Okay, there are different types of this implants. That is Ahmed Wall. Then our own Arvind Eye Hospital has designed a wall called Arvind Eye Wall. Then there is Molteno, Berwald. These are different types of vault. Just you have to remember the names. Okay, names are important. Some of these are valve, that is there is a valve present here. If IOP increases more than a set point, these valve open and the aqueous is drained, and some of them are non-valve, that is there is no valve present and there is continuous drainage of the aqueous humor. Okay, this much you have to remember. The recent advances in this part is the mini shunts. Various mini shunts are available like iStent and Express mini shunt. These are nothing but the shunts available. You have to insert them into the trabecular meshwork and they drain the aqueous humor from the anterior chamber through the normal or conventional pathway. Okay. These are nothing but the microscopic surgeries. These are microscopic structures which are there and you have to insert it here. I was telling you about trabeculectomy. There are some indications where you have to do early glaucoma filtration surgery. I told you that treatment of choice for primary open angle glaucoma is medical, but there are some patients where you have to do surgery. So these are the advanced visual field defects at presentation. That is, if there is visual field changes within the 10 degree of the fixation, and those patients you cannot control that IOP with just by medicine. So there you have to go with surgery. Or if you follow up patients every 3 monthly and you are seeing that there is a rapidly progressive visual field, that means your drugs are not acting or target IOP is very low, and a drug have some side effects, and those cases you cannot decrease IOP beyond a point. Okay, so those cases where you want a very low target IOP, those patients you have to do surgery. Or if patient has non-compliant, and very important is intolerance to medical therapy. So these are all indications for surgery. Now what we do in the follow-up, once you have done put patient on medical therapy, or once you have done this surgery, your job is not over. You have to call patients every 3 monthly or every 2 monthly, depending on how much is your target IOP, and depending on the how much is damage to the damage in case of visual field. And with on every visit you have to see patient's IOP. If it is maintained, you have to examine the optic nerve head, whether it is there is increasing pallor or the cup is not increasing, that you have to keep in the mind. And you have to see whether any what are the changes in the retinal nerve fiber layer thickness. So all these, once patient comes after surgery or after starting medical therapy, you have to see. So how target IOP is achieved? First you have to start with medical therapy. If not controlled with the 3 drugs, you have to go ahead with laser. But there are some exceptions where you can do argon laser and selective laser first. Okay. Next step, you have to go with surgery, that is trabeculectomy, if medical therapy and laser fails. Last is you have to do with the shunt procedures and other procedures. So the early aggressive therapy is where we use combined drugs and argon laser if the target IOP is very high and there is rapid progression. These are all the previously I told you the same indications. Okay, so to summarize the treatment, choice of target IOP should be individualized for each patient, and we will start with medical treatment as monotherapy. And if it is not good, then it is change it. If good, then it is we add adjunctive medications, and we start by aggressive treatment in some cases, especially where there is a rapid change or there the patient has more of RNFL loss. Okay. The very important is red flag sign. What are the red flag signs in glaucoma? That means patient has all the features of glaucoma, but actually patient is not a case of glaucoma. When there is a visual acuity is out of proportion to the cupping. Suppose you see a patient who has 0.4 cupping and he is having hand movement or counting finger. 0.4 of cupping will not produce such drastic change in visual acuity. So those patients you have to remember. And when there is red green change in the color vision chart, so if there is optic nerve damage, it will produce blue, it will produce some kind of damage. In cases of optic nerve damage, you will have some kind of color vision loss. But if it is lost disproportionately, that means these fibers are affected, then it is some neurological problem. The patient has some underlying neurologic problem that you have to keep in the mind. And when the optic nerve pallor is out of proportion to the cupping, like there should be the cup should be there, and adjacent to cup a rim should be there where normal ganglion cells should be present. If it is not there, that means the patient has pallor which is out of proportion, and you should see these patients, because most of these patients will have some underlying neurological pathology, some pituitary adenoma or some other brain tumor or something will be there, craniopharyngioma may be there, or patient will have any secondary optic atrophy due to any other cause. Okay, maybe due to papilloedema or something. So you have to remember. And when the fundus abnormalities are there like optic nerve pit is there, drusen or tilted optic disc is there, these cases you have to be very careful in treating. Okay. Thank you so much. Next time, next class, I'll be talking about primary angle closure glaucoma and chronic angle closure glaucoma. Thank you.